Good afternoon, everybody. I'm in Brussels as usual, and Elpa today has the honor to host a new principal investigator of liver screen, Dr. Isabel Graupera. Thanks for joining us today. She's a gastroenterology and hepatology expert, holding a faculty position at the liver unit of Hospital Clínic in Barcelona. She's also leading the specific area of non-alcoholic fatty liver diseases, NAFLD, at the same hospital. And their current research line focus on understanding molecular mechanism responsible for the progression of this disease, NAFLD. It's a pleasure. In the framework of the project, she is working in the activities related to the work package number 4, called Data Analysis and Exploitation of the Results. My first question for you is in regards of the project from a broader perspective. If I'm surfing the website, the first thing that I can read is Liver Screen project will screen a total of 30,000 people. And this is quite striking, no? From a, not only from a patient point of view, but for a not doctor point of view.
Yes, I can agree with you. Nice introduction. Thank you very much, Beatrice, for introducing me in this kindly manner. I have had the honor of being involved in liver screens since the very beginning. This is a project led by Professor Pera-Ginés, which had the idea of this project. And because I'm working with him for a long time, I was involved from the beginning. And when he said like 30,000 patients, I was like, wow, I mean, this is a monumental study. Plenty of challenges that we have been facing over the past years. But I understood that it's really a necessity. I mean, there are different approaches that have been done in the research field, trying to understand which is the best strategy for screening, but all of them have been with smaller cohorts of patients, and we cannot have a conclusion about the best approach, the best strategy, the best pathway. So we needed a big project englobing all European countries, not all, but most of the European countries, or at least different countries from different regions, north, south, east, and west. So we would have a big picture, not only like a country-centered, but from all Europe. Also because we are trying to understand the best strategy using transient elastography. And as you well know, or maybe patients don't know, but transient elastography is a non-invasive device that allows you to quantify the amount of fibrosis in the liver. In the past, we have been using liver biopsy, but liver biopsy is not good for screening. So we are using transient elastography to do that. And we need a high number of liver biopsies in order to compare with our transient elastography. We're not gonna do a liver biopsy of the 30,000 patients, only of those patients that we suspect that have an advanced liver disease. So the more amount of patients that we get into the project, the more that we can compare with liver biopsy, and the more exact the transient elastography will be and will give us more information. So there are different reasons for these 30,000 patients.
So if I well understood, we have a shift in numbers, so a bigger cohort of patients, so a huge cohort, and then a shift in the technique you are going to use to screen patients.
Yes, in fact, liver biopsy has never been like a screen tool. It's been more like a diagnostic tool, okay. But in the end, it's the gold standard diagnostic tool. No, you can tell patients with serum biomarkers or with abdominal ultrasound that they may have a liver disease, but until you don't perform a liver biopsy, you don't. Sometimes we did not have enough information to tell the patient how sick, how severe the disease was. Now with transient elastography, that was like, it appeared in 1999, more than 20 years ago. Now we are using in clinical practice for diagnosis, for prognosis, to follow up patients. And we want to move that to screening, to use in a broader strategy for all patients and in primary care mainly. That's one of the most interesting things of the project, is that it's not only involve doctors and nurses from tertiary hospitals, but it is built in primary care setting, involving the nurses and the physicians from primary care, which are the ones that are most in contact with patients that need to be screened.
So then what are you going to do with this amount of data? I suppose it concerns your work package.
Yeah, I think that I'm very happy to be in leading this work package. I think for me, it's the most interesting part of the project. I think the challenge goes for work package 2 and work package 3, my other colleagues, because they have to include all this amount of patients in the different countries. We all work together. It's not that they only work on that. We all work together, but they have a huge work, because we need all these amounts of data to understand not only the best strategy, but also which are the patients that need to be screened. We know from studies with smaller cohorts that maybe we don't need to screen everybody. Maybe it's better if we screen patients with risk factors for chronic liver disease, in terms of one of the two major chronic liver diseases are alcoholic liver disease and non-alcoholic fatty liver disease. So maybe only those patients with high consume of alcohol or with metabolic syndrome risk factors should be screened. That's what the studies have been telling us, but there is no study with this kind of strategy in the primary care setting. So first we have to get all this data, analyze them, and say, yes, when you screen the general population, you find that only those with with risk factors are worth screening, because are the ones with potential liver disease. We are also looking at it in the public health perspective. We would like to screen everybody, but we cannot do it. So let's go for those that have more probability to have liver disease. That's what we need, 30,000 people from general population. Some of them will have risk factors, some of them will not, and we will be able to prove our hypothesis that only patients with risk factors will need to be screened.
Is it also a way to understand the risk factors more? So how they are like spread in different countries? This is my curiosity. It's
I think that we will see that the different cohorts from the different countries maybe will have different percentages of risk factors, no? And we will see if these risk factors in this kind of population are more associated with advanced liver disease or not. So we will have a lot of information, not only about the prevalence of patients among Europe with advanced liver fibrosis or with significant liver fibrosis, the percentage of risk factors, and the differences between countries, for sure. One of the studies, which is, we have two main studies in liver screen. One is the cross-sectional study that will include 30,000 patients. And then we have the longitudinal study, which is a cohort of more than 4,000 patients that will be screened in 2 time points, at the beginning and then after 5 years. With this longitudinal study, we will be able to understand how the risk factors impact on the progression of the disease, and which is the best time frame for re-screen patients. So we are very excited about the data that we are going to get, and we will do like a lot of analysis.
Yeah, for sure. I was also thinking that would be, I mean, all these data could be also the basis for prevention programs.
Yeah, that's the main reason of the liver screen program. There is one of the parts of the project is to evaluate an implementation program. which means that once we have all this data and we have analyzed this data, it's not the same doing as a part of an investigational project, but as a part of a clinical databases. So the implementation program will try to perform the implementation of the strategies that we think it's best. Maybe we find that only diabetic or only obese or only alcohol abusers will need to be screened. It's just an hypothesis. It's not what we are doing. It's just finding the best risk factor and then implementing the strategy in some of the countries involved in liver screen. So yeah, we will have the information not only about how to implement it, but also if we succeed implementing it. Because it's not the same when you do it in an investigational project that when you do it in real life. You face a lot of problems doing that. So yeah.
That's clear. Thank you very much. For patients and for people who are not familiar with the scientific project, it's also difficult to understand if there are some results during the project, because our projects that are going to last 5 years, 6 years, 7 years, even more sometimes. In the liver screen project, is there already something that you can see and that you have already assessed?
Yeah. Okay, we have faced so many problems since the pandemic, because including patients in primary care for investigational purposes, it's been difficult. But all the investigators have been very committed, and we have already 16,000 patients included. And we know that the prevalence of liver fibrosis are more or less the same that we had in previous studies. So that was expected. So we know that the project at least is what we expected to find. And we have made small analysis with this cohort just to see how it goes and the amount of percentage of risk factors in the population. So, and as you said before, we have found a little bit differences between countries, which is really, really interesting. But I think that we will wait until the end to give the big picture of the project, because we want the big picture to give the best strategy. Yeah.
Well, thank you very much. It was interesting as usual. And I wish you all the best for the project and for your personal and working career.
Thank you very much, Beatriz. It's been a pleasure. Bye.